Good morning, judges and audience. My case series was on two cases of Laren syndrome. Coming to Laren syndrome, it is an rare autosomal recessive disorder and is caused by because of mutations in the GH receptor, and this leads to GH and IGF-1 signaling pathway defect. The prevalence is about 1 to 9 in 10 lakh population. And how to suspect? Whenever the GH levels are normal or increased, IGF-1 will be markedly low, and they'll have features of severe short stature and characteristic facies such as depressed nasal bridge and protruding. They'll be having protruding forehead. Coming to case 1, he's a 4-year-old male born out of 4th degree consanguineous marriage via LSCS. If the chief complaint from the parents is that he is having gross motor and speech delay. His birth weight is 3.36 kgs. When we have examined, he had complete dysmorphism. He had large ears, depressed nasal bridge and protruding forehead. Coming to his anthropometry, his height is 74 centimeters, below 3rd percentile. Weight is 10 kgs, BMI is 18.3 kg per meter square, and mid-parental height is 165 centimeters. Its head circumference is 42 centimeters. Upper segment to lower segment ratio is 1.41:1. Stretch panel length is 1.5 centimeters. Bilateral testis is of 1 cc. His TSH is the TFTs, CBC, LFTs, RFTs, and electrolytes including calcium, phosphorus, and vitamin D were in normal range. His basal growth hormone level itself is 40.46 nanogram per ml. His 8 am cortisol is 8 microgram per deciliter. We have gone ahead with stimulation with clonidine. The all values at 30, 60 and 90 minutes, it showed greater than 7 nanogram per ml. Because he is having high index of suspicion with because of gross dysmorphic features, and because of non-suppression, because of high GH, we have suspected in him some kind of GH resistance. So we have taken opinion of genetics also. So based on their opinion, we have directly gone ahead with whole exome sequencing, and whole exome sequencing showed GH gene pathogenic mutation at intron 4 and exon 5. Coming to our case 2, he is a 12-year-old male. The chief complaint is by his parents is of short stature compared to his peers. His height is 109.6 centimeters, that is below 3rd centile, and weight is 22.7 kgs. BMI is 18.9 kg per meter square. His stretch panel length is less than 5 centimeters. Bilateral testis is of 1 cc, and pubic hair is of P1. His TSH is 1.2 international units per ml. Cortisol is 9.18 microgram per dl. His clonidine stimulated growth hormone 2 values were above 7 nanogram per ml, that is at 30 and 90 minutes. His IGF-1 level is less than 25 nanogram per ml. Because they are non-affordable, we haven't gone ahead with whole exome sequencing. So here, because of high GH and low IGF-1, our provisional diagnosis for this case is also Laren syndrome. Coming to the diagnostic approach that is provided by Salvage et al. How to diagnose Laren syndrome? He had given 7 parameters. He is one of the scientists who had done thorough research on Laren's. Whenever height SDS is less than 3 SD, basal GH is greater than 2.5 nanogram per ml, which is present in our case 1. Basal IGF-1 of less than 50 microgram per liter, present in our case 2. Basal IGF BP3 of less than 2 SD. IGF-1 increase post IGF-1 generation test less than 15 microgram per liter. IGF BP3 increase post IGF-1 generation test is less than 0.4 mcg per liter, and GH binding of less than 10%. And diagnosis is made when 5 out of 7 parameters is met according to Salvage et al. But because of logistic issues, we are not able to do all these in the second case. But in the first case, the gold standard, we have proved it with gold standard, that is whole exome sequencing. When we should suspect Laren's, whenever the patient is having short stature with normal or high growth hormone and low IGF-1. Why this occurs? Because whenever there is a GH receptor mutation, GH acts on the GH receptor, but it will not produce IGF-1 because of mutation. Low IGF-1 one causes because of loss of feedback. There will be high growth hormone because of low IGF-1. And we have to suspect Lawrence in patients with other features such as dysmorphic features, facial dysmorphic features such as saddle nose, front protruding forehead, and whenever he is having alopecia and along with consanguinity, and they will be having gross motor and speech delays. And coming to other clinical features, they include midfacial hyperplasia, truncal obesity, high-pitched voice, small genitalia, that is they are having micropenis, they are having hypoglycemia, delayed puberty, underdeveloped muscles, they will be having acromicria, that is small extremities, frontal bossing will be there. Coming to treatment challenges, recombinant growth hormone, that is mecaserine, the cost itself is greater than 15 lakh per year for 20 kg child. It will be given in 75 mg per kg per day, daily 2 injections subcutaneously. Limited availability is there in India. There will be various variable response to this. Conclusion is we have to it is a treatable cause but it is rare, so we have to diagnose it early, so that the recombinant growth hormone works if you diagnose it early, but it is inaccessible to many. Socioeconomic barriers include high financial burden and limited access for genetic testing, as well as limited access for the drug. There is so much need for drug availability and awareness. Thank you. This is people in Ecuador, almost about 100 people of Ecuador, they suffered from Raynaud's syndrome. They have requested the government several times, but the government had involved in importing the drug after several years. By the time they have imported the drug, all these people became adults, and it's of futile. Thank you.
Yeah. Why is there speech delay in these people? Speech delay.
Actually, this we have seen various articles. Motor delay will be there, but the speech delay, the hypothesis is not able. Even hypothesis is also not there in these cases. Why it occurs?
Yeah. How is the inheritance pattern? Just for my information.
Inheritance pattern, whenever both mother and father are carriers. Mostly in autosomal, so it leads to autosomal recessive state only. All the cases were in autosomal recessive state only, and because it is passing via generations, such as because it's mostly seen in population basis, like in a cluster, such as in Ecuador, or initially when Lawrence syndrome is found, they have found it in Jewish descent from Yemen. So the mutations, they occur in clusters in populations rather than in different people. So maybe this is because of that autosomal recessive pattern which is being carried out throughout the years.
Just one small doubt. This Ecuador, no, like if the IGF-1 is not there, the bone also will not fuse, no? So can't they treat later also, or?
So can't they treat?
Means the children you told they have become older. Yes. In Ecuador.
Yes.
So the bones will not have been fused, no? They can still undergo treatment with IGF-1. How is the puberty in those?
Puberty is somewhat delayed, sir, but bones were fused. That's why they are not able to treat, because of estrogen effect. Growth hormone got closed.
This question regarding your second case.
Yes, sir.
You mentioned in the stimulation test, GH provocation test, 2 values more than 7.
Yes, sir.
What about other values?
Some studies they show, in our study, sir, or
in your patient?
In a patient, one is 26, sir, and other one that is at 30 minutes, and at 90 minutes it is 23, sir, whereas at 60 minutes it is 17, sir.
17. All were above 10.
All the values.
It's better to put all were above
all the
10.
values.
Okay. Yeah. Then is there any role for random GH in evaluation of short stature?
Yes, sir. Specifically
in short stature?
No, sir. But specifically in not random, sir. But specifically in Lawrence, whenever the basal growth hormone is very high, such as in first case, even 46. So
I can ask it in another way. When will you do random GH in a evaluation for short stature in your practice?
Whenever the patient is having other hypopituitarism features, then
Will you do that?
it's not suggestible, sir, according to the guidelines. But one value, not random, but basal maybe.
No, I will say only if you're suspecting larynx, you can do that. Otherwise, you don't do that.
Yes.
Okay.
Yeah, yes, yes. Pardon me? Yes, ma'am. Whenever we suspect specifically. And the one more is that they have stimulated IGF-1 after giving they have tried to stimulate IGF-1 after giving growth hormone. That is one of the dynamic tests in larynx. So whenever if the IGF-1 doesn't increase even after stimulating with recombinant growth hormone, that is one of the dynamic tests which is used to diagnose.